Well, thank you very much. As Diana said, I am a clinician. I'm also an epidemiologist. I work at INSERM in Paris, in France. It's the National Institute for Health and Medical Research, where I work as an epidemiologist on perinatal epidemiology. But last year, so what I'm going to talk about here is the impact of the coronavirus pandemic on perinatal activity. I was going to try and answer the question, what's going on? And to give you a little bit of an answer towards that. But slight spoiler alert is that I don't know. It's been a lot more problematic than I thought it might be. So this talk is going to be a little bit about the story of what I was trying to do and what I've managed to achieve. So I'm going to start just by giving some acknowledgements to my collaborators in this. I worked with 4 people so far, with Kath Harrison from the Embrace Transport Service, which is based in the Yorkshire and Humber region, and I'll tell you a little bit about that in a second. Elizabeth Draper, who's at the University of Leicester, and Liz is involved in, she runs the department, the Infant Mortality and Morbidity Studies department, and she's co-lead for the Embrace UK confidential inquiry into various perinatal factors. And then the other 2 people who are involved was Charlotte Bradford and Hilary Farrow, who are from the neonatal and the maternity networks, respectively, in the Yorkshire and the Humber region. And none of us have any conflicts of interest to declare. So just a little bit about Embrace. I was very fortunate last year to be able to spend some time working with Embrace Transport Service. The Embrace Transport Service is a specialised inter-hospital transport service. It transfers newborn and critically ill children in the Yorkshire and Humber region and performs about 180 transfers per month, around about 3/4 of which are neonatal transfers. And my background, as Diana said, is I'm a neonatologist. I worked previously in London, and I've done some work as well in the Paris region. Embrace covers 15 NHS trusts, but there are actually about 20 hospitals, ranging from level 1s, which are the lowest intensity. They have essentially births that are predicted to be well births, well labours, well pregnancies, and ranges through to the level 3 units that accept babies that are the sickest and the most premature. And there are 4 of those level 3 units in the Yorkshire and Humber region. And Embrace also has responsibility for arranging antenatal or in utero transfers for women who have threatened preterm labour. And so one of the things that obviously happened last year was the whole COVID-19 pandemic overtook us, and actually made it very difficult because I was traveling backwards and forwards between France and England to do work. And so it became very difficult to do that work. And so we wondered if there were other ways that we could use my skill set. And one of the ideas that we came up with was to look at the impact of COVID-19 and the pandemic and the public health measures that were associated on the perinatal workload that we were experiencing. So this was triggered by the fact that there were 2 early studies. The first one came from Denmark, and they published some data that showed that there were decreased preterm births. And one of the hypotheses that was postulated was that there were perhaps decreased infectious triggers for preterm birth, or perhaps women were less stressed, they were not working so much at work and in such stressful environments, and therefore may have had less of a trigger for having preterm birth, and this may have impacted things. Then there was another study that came along, and this came out of London, and it showed that there were increased stillbirths. And so the other idea that came out was that perhaps women were scared to go to hospital. And so when they were going into preterm labour, or when they were having difficulties, they were not going to hospital because they were afraid of getting COVID. And therefore they were just staying at home, and their babies were unfortunately dying. So we wanted to look into this in more detail. There was quite a lot of anecdotal evidence around in the pediatric and the neonatal communities saying that there had been fewer transfers going on. So there were fewer women being transferred antenatally, there were fewer postnatal transfers, it seemed. The neonatal units were saying that they were not as busy. And we also knew that many of the pediatric intensive care units had been converted into to have the capability of looking after adults. So we decided, as I've kind of indicated already, to investigate the impact of SARS-CoV-2 and the related public health measures, known in England and the English-speaking world as lockdown, and in the French-speaking world it's called confinement, on the perinatal health indicators. So these were the specific questions we wanted to try and answer. Using a geographically defined population in relation to pre-pandemic times, and most people were taken as a baseline the last 5 years, had there been any changes in the birth rates, particularly the live births and the stillbirths and the preterm births, but also in birth-related morbidity, so asphyxia or other problems that might be related to delayed presentation, and were there any changes in place of birth and the associated transport activity that was going on. And we wanted to look specifically during the first wave of the pandemic and the associated lockdown, because that was what people had been describing. This went from weeks 13 to 25, March 23rd to June 15th. And then the other thing, obviously, that was important, a lot of people were talking about, was the role of ethnicity. And so we also tried to get data about ethnicity so that we could see if there were any differences. Just a little bit about the Yorkshire and Humber region, for those that don't know. This is where it's situated. It's kind of up on the northeastern side of England. This is a zoomed in picture, and you can see that there are essentially 5 regions within the overall region. West Yorkshire and South Yorkshire are probably the most populous parts, and they're where the big urban conglomerations of Sheffield and Leeds and Bradford and a lot of other dense places are. North Yorkshire is quite a much more rural area. And then there are quite a number of people around the Humber River, which is that bit coming in with a bit of Lincolnshire and East Riding of Yorkshire. Compared to the rest of England, it's got an older and a less ethnically diverse population overall. There is poorer life expectancy and a higher proportion of children in lower income households. And as might also be expected to go with this, there's a higher infant mortality rate that could be associated with the poverty. There are around about 5.5 million people overall. I think this is about 8, 9, 10% of the UK population, a little under 10% really. So it was a reasonable size and certainly comparable to some of the other studies that were coming out, for example, Denmark. We felt that there were a number of sources that we could use for data. And so there'd been a report in 2016 that suggested that there should be a maternity services dashboard, and there was subsequently created a maternity services data set, and it was felt that this could serve as one possibility for providing us with data. There's also, as I mentioned, Liz is involved in Embrace UK, Mothers and Babies Reducing Risk through Audits and Confidential Inquiries across the UK, and they gather data about all the stillbirths and the perinatal deaths that occur in the UK. And so that could have been an option for getting data. And then we were also thinking of getting data from Embrace and from the neonatal network. Now, it turns out that actually, unfortunately, these first 2 options were not possible. They did not have complete data. They were only set up after the 5-year period had started, really, proceeding when we wanted to look at. But the legal basis for the maternity services data set only arose in 2018. And there were not complete data for any of these things, nor were there data at the granularity that we wished to have, which was weekly data. There was only monthly data available. The other problem was that Embrace UK, well, they only provide data after they have published it, and if you can pay a fee to support their services in extracting the data and so on. And the most recent data that they had published was 2018, and there was no way that we were going to be able to get 2020 data to look at. So that we also had to rule out. And so that left us with only one possibility, and that was approaching all the hospitals individually. We were also, however, able to get data from Embrace Transport Service because I was working there along with Kath. And we had collaborators from the Yorkshire and Humber neonatal network that allowed us to get the neonatal data that we wished. So this is a summary of the data that we wanted. In terms of the obstetric data, we wanted to look at the number of women delivering, but the number of babies that delivered as well. So for example, if one woman delivered 2 babies, that would be 1 woman and 2 deliveries, 2 babies. Split that into live births and stillbirths. From Embrace, we wanted data on the pre and the postnatal transfers. And then the neonatal network data we decided to look at was the less than 27-week births, because these are all pretty well recorded on a neonatal database, a clinical database, and also the babies with hypoxic ischemic encephalopathy, so those with perinatal asphyxia, and babies with meconium aspiration. And because there is some variability in how these are defined, we said that the babies with HIE would be those ones that got active treatment with a cooling therapy and were recorded very well. And the babies with meconium would similarly be those that had specific treatment with nitric oxide for meconium aspiration. Unfortunately, we're still waiting for data. We couldn't get the neonatal transfers data yet. We couldn't get the babies with meconium aspiration syndrome. These data are coming, but I haven't been able to get them, so I can't present any information relating to those. Similarly, we've had huge difficulty with the obstetric data. We got all the data from all the hospitals through to week 40, which was when we started the study back in October, November time. We got agreement, but there are a number of trusts who did not provide us with any historic data and a number of trusts that did not provide us with any ethnicity breakdown. And so we've had to keep on going back to the trust to try and get these. And because of that, we decided to extend the study to include all of 2020. And so that's why there are some trusts there that are listed as only having part supplied the data. So we're still waiting for the rest of the 2020 data. And we still are waiting for this historic data as well. Well, of course, we can, in fact, first, this is what it looks like. This is a chart of the missing data. So the light gray shows the data that we have. The black shows the missing data. And across the top, we have the different variables that we were trying to collect. The first three variables here at the beginning are just the hospital name, the week number, and the date that the week began on. And so those are complete because I was able to fill them in. The top of the chart represents the historic data. And so each line, essentially the black lines, represent a hospital trust that has not provided complete data for those data variables for the historic 5 years that we were looking at, that we were requesting. And then there's a bit of missing data in 2020, which is the bottom part of the chart as well. Of course, it's possible to do something about this. We can use multiple imputation. So imputation is the process of replacing missing data with substituted values. There's statistical methods that allow you to estimate the data. And so what you normally do is you start with a data set. It has a missing data. So what you do is you impute multiple data sets, hence the name. You then run your analyses across these multiple data sets and you pull the result to give you a final single answer. That's what this diagram on the bottom left-hand side shows. There are some assumptions that are based on, that this is based on, and this is based on the pattern of missingness. And so there are three types of missingness. There's missing not at random. In that case, there's no pattern at all to the missingness. And so you don't have to actually do anything because your results will be unbiased. Then there's missing at random. Sorry, there's missing completely at random. That's what I just described. And then there's missing at random. And when you're missing at random, there's a pattern to the data, but you have other data that explain that pattern. So this is missing at random. And then finally, there's missing not at random, when there is a pattern to the missingness, but the data that you have do not explain that pattern. And so you don't really know what's going on and your results will be biased. Well, of course, we've seen already that our data had a pattern. We have both hospital and date that explain quite clearly what was going on. So it should theoretically have been possible to impute the data. Unfortunately, when I tried to do the imputation, this is what we got. We got complete data for everything, so there are no missing data. But when we plot the individual data sets, we see this pattern. So I created 40 different data sets, and we have this higher number at the beginning. This is the number of women delivering by week, and then we have a dip in 2020, and then we have a slight fuzziness, should we say, at the end. And this is repeated across all of these data sets. It's also repeated for each of the main variables. So this is the number of women delivering. This is the number of deliveries. We see that there's this dip, exactly the same in 2020. This is the number of live births, and same pattern again. This is the number of stillbirths, and this is the most remarkable. So there seem to be fewer stillbirths in 2020. But actually, when we look at that, we zoom in a little bit, we realize that this is a major problem, because this was not 2020. This is just a single data set. This is not 2020 during the lockdown. This is the whole of 2020 that there are fewer stillbirths going on. We can see that here. And the reason that there are fewer stillbirths going on is because these are accurate data. These are the data that have been reported to us, and these are true data. Whereas the other data that are previous and that are afterwards are the data that are imputed. And so these are the missing values that have been imputed. So there's something going on, the imputation is not working, and we can't really use that data. So what could we do instead? Well, we decided that it was possible to look at only 2020, and then we could try and figure out whether there was something going on. So this is the number of stillbirths per week for 2020, and we can see that they range in the region from 0 up to 8. Most of them are sort of 2 to 6. And actually it's fairly constant through the year. We could highlight here the weeks that occurred during the lockdown. So remember I said this is from weeks 12 to 23. And when we do this, we see that actually there is no real difference. Just from looking at it, we can see that there's no real difference in the lockdown period to what was going on and to what was going on afterwards. We see the same sort of pattern with live births. So there's, again, no real difference. Are there fewer live births? Probably not. Are there fewer deliveries? Again, probably not. Are there fewer women? Again, probably not. There's some statistical fluctuations. Maybe you could argue that there are fewer women delivering. I'm not convinced personally. These numbers on the y-axis here run from 950 through to 1100, but most of them are 950 to 1050 in the region over a weekly period. And so I wouldn't say that there's very much going on. So no changes. Well, no obvious changes in the number of women delivering or in live or stillbirths. But the original questions really primarily related to the morbidities and to the place of birth. So what about if we look at those things? The woman who extracted the neonatal data for me sent me this, and this was quite an interesting table. She highlighted the average number of admissions per week for each of the previous 5 years, 2015 through to 2019, and then for 2020, it was this is the average number of admissions over the first 40 weeks of the year, for which was the time periods when she sent it to me. She then looked at the weeks 13 to 25 and the weeks 26 to 40. And we can see that actually over the course of the year, there's no real difference. And 2.58 admissions per week doesn't differ massively from previously. Similarly, the 2.62 during the lockdown period, the weeks 13 to 25, doesn't differ massively from previously. But what we do see is this figure here, the 1.88. And it seemed that over the weeks 26 to 40, so the post-lockdown period, there may have been fewer births. Now, one caveat to that is that there were 3.44 in 2017, 2.69 in 2018, 2019 in 2.25 in 2019. Was there a downward trend anyway? But we could look at that. So I did a similar thing as I've shown before, and I plotted it in different colors here. We can see that there's a greater spread of extreme preterm births. This is the birth rate per 10,000 deliveries, including live and stillbirths. There are perhaps slightly fewer, perhaps the same during the lockdown periods, and then a kind of more condensed part in the weeks 25 to 40 that we had complete data for. Same thing when we look at live births. It doesn't really change that much. It changes marginally, but there are very few stillbirths. So I think as a kind of summary, I have to say that there are no obvious changes. There are a number of caveats to this, and we could look at the earlier studies again. So we could go back and look at the earlier studies that I mentioned earlier. Denmark decreased preterm births, London increased stillbirths. What was going on there is what they found really that different from us? And when we look at it, actually the Denmark study, they only looked at neonatal admissions. So they probably missed births well, they missed all the births. They missed children that died in the neonatal room. They missed, in the delivery room. They missed children that weren't admitted to neonate. So there may have been some bias going on. They may have lost some things. In London, actually, it was a single tertiary hospital. So there may have been changes in a single tertiary hospital. It may have been that all the women decided to go there and weren't going to the other hospitals. But it doesn't reflect a true population change. So that's essentially biased as well. And then there's been a number of other studies, obviously, since. There's someone, Jim Thornton, who's collected a whole bunch of data, all the studies that have been published on this kind of data. So the link is there. There was a study in Ireland. They showed that there were decreased low birth weight and very low birth weight live births. But again, it was a single region, population of under 500,000. They had data for quite a long time period, but the lockdown was very small and the confidence intervals were quite big. Then there were other bigger areas. So there's California, there was a study that was published. They showed no change in preterm live births and they used routine data. There was a study that used the whole of England and they showed no change at all in stillbirth rates. And again, that was using routine data. There was a study in Sweden that has just been published recently that showed no change in preterm delivery or stillbirths, and they used register data. And then most recently of all, there's been a study just published in the last few weeks from Spain, and they did something similar to what we were trying to do, was they took data from a single region and they found from all the different hospitals, there were again about 13 hospitals, there were no changes in preterm delivery or in stillbirths. So I think there's still stuff that we need to do. I need to obtain the full data for all the hospitals. I need to try and avoid imputation. It may be that we have more power with a longer time series. And so if we have the data from previously and we have more data from 2020, that could be could help to answer some of these questions. There still then remains the question, what time period should I use? Should I use just the lockdown period and then have a separate period for the post-lockdown, but then there's the second lockdown that occurred in October, November time, or should we use just a pre and post-pandemic cutoff and see if there are differences from March onwards compared to previously? Another thing that I intend to do is to create an adverse outcome indicator, the hypothesis being that there were increased adverse outcomes, so perinatal asphyxia, meconium aspiration, stillbirth, preterm birth, but these aren't always in they aren't always in the same direction. So it may be that there are more stillbirths and fewer preterm births, or more stillbirths and more asphyxia, or it's not entirely clear how this will work out. And then the other thing that I plan to do still is to look at the place of birth, and more specifically at the transfers that were going on. Was there a change in place of where women were delivering? I think there are some conclusions that we can draw, though. I think SARS-CoV-2 overall effects, there's probably not much of a link between SARS-CoV-2, the public health measures that were being taken, and perinatal health on a very broad kind of level. But I do think that there are probably behavioral effects that are going on and that they're quite subtle and the numbers are small and it's difficult to pick these up, and they're going to change region by region. And so it may be that women in a certain region, depending upon the access to their local healthcare services, do have differences, and that those kind of differences don't show on larger scales, larger areas. So it's a difficult thing to disentangle, because obviously when you've only got a few people and you've only got a few cases, then you don't really know what's going on. So I would say watch this space for more definitive results as data come in. But I also wanted to highlight this paper. This is a very interesting paper. It's about a slightly different topic. It was published in the IJE in 2018, and it's a new view on the global mortality burden of the 1918 influenza pandemic. And we certainly don't want to wait 100 years until we get some of the results, but I think it is going to be time before we get some of the answers to some of these questions, and some of the questions we may unfortunately never be able to answer. And so there are also some broader, more general learning points. So I think a very big, good learning point is that data cleaning is very important. Understanding your data is very important, and just looking at it is really necessary to try and decipher what is going on. This is obviously the data scales that I'm looking at. The data sets are much smaller than some of the ones we've heard about earlier today, but they're also equally important in understanding health impacts. The other thing is that data collection is hard, even in countries with good data systems. And I think this comes from the previous speaker and from other talks throughout the day. The UK has one of the best data collection systems in the world, certainly compared to France, where I'm at the moment. It's far, far better. and there are a lot more data that are available. But the problem is that they're all in silos, and these silos hinder knowledge, and it becomes very difficult to pull them together. And so we need to work on ways of opening up the data and making it more accessible. The thing that Diana mentioned in the introduction, I'm involved in a project called Data Shield. It's based at Newcastle University, and that's something that is a tool that can be used for accessing data remotely, or doing analysis remotely, so that you can use federated data, for instance, um, to try and answer questions without giving researchers direct access to confidential data. But that also could be an entirely different talk and subject. So that's it, really. I just thank you very much for listening to me and for inviting me to talk.